afternoon. Thank you for joining us today. I am Molly Sutter. I'm the Interim Executive Director at Nashville Health, and we are pleased to partner with the Nashville Healthcare Council to bring you this important discussion today. As we begin, I want to thank our presenting sponsor, Bristol Myers Squibb, for making today's event possible. We're extremely grateful for their partnership. This past year has forced all of us to adapt and adjust the way we care for and manage chronic conditions. As we emerge from the pandemic, how do we re-engage with patients? What can we learn from shifts in care management and new engagement tools? And most importantly, how do we move forward in reducing and preventing disease? Today, we are excited to begin our program with Dr. Janet Wright, who will share with us about hypertension as a national priority and a renewed call to action to improve our nation's heart health. Dr. Wright is the acting director of the Centers for Disease Control and Prevention's Division for Heart Disease and Stroke Prevention. A cardiologist and expert in her field, Dr. Wright has served in leadership roles with the CDC and the Office of the U.S. Surgeon General, including as executive director of Million Hearts, a national initiative to prevent 1 million cardiovascular events over 5 years. I am proud to share that while Dr. Wright practiced medicine on the West Coast, she received her medical degree from the University of Tennessee. Now, before I turn it over to Dr. Wright, I want to let you know that we will be taking questions via the Zoom chat feature. So please submit any questions you have for Dr. Wright during her presentation using the chat feature. Now, it is my pleasure to introduce Dr. Janet Wright.
Thank you so much, Molly, and thank you to Nashville Health and the Nashville Healthcare Council. It's my pleasure to join you all today. And as Molly said, I am a proud Tennessean. I did grow up in Arkansas, but I grew up in a Big Orange family. My father went to Knoxville and Memphis, and so did I. My mother was a Memphian. My dad was actually born in Lawrenceburg, or actually in Etheridge, south of Nashville. So I have very fond memories of my adopted home state. And it's a pleasure to join you all. I want to thank you for the work that you've done to improve the health, the lives, and the livelihoods of Nashvillians. Today, we're going to use hypertension as a use case, or I hope to make the case for you that a focus on prioritizing hypertension control will have incredible returns in health and also in productivity and help reduce costs of care in the state of Tennessee and certainly in Nashville. So with that, I'll just move my slides ahead for whatever reason. Oh, there we go. So if you take away 3 or 4 points from my talk, really the important ones are here on this slide. High blood pressure or hypertension is incredibly common. 1 in 2 adults in the United States has high blood pressure. And we're defining that as pressures over 130 on the top and over 80 on the bottom. The national control rate is incredibly low. In fact, it's around 1 in 4 people with hypertension actually have it under good control. 1 in 4 adults. And I think even worse news is that trend of control has been dropping over the last 5 to 8 years. Multiple reasons for that, and happy to discuss those further in the Q&A if you would like. The importance of hypertension is that when it is uncontrolled, it causes multiple types of events, all of which are largely preventable when hypertension is controlled. So we know about heart attacks and strokes, but uncontrolled hypertension is one of 2 major causes of kidney disease and kidney failure, along with diabetes. We also know that when people who control their hypertension in midlife are less likely to experience dementia in later life. That connection is now scientifically solid. And then there are a number of complications of pregnancy, which lead to bad outcomes for the woman and for the baby or fetus, but also mark both of those, both mom and fetus, for lifetime increased risk of heart disease, stroke, and other forms of cardiovascular disease. One of the things that the two things that gall me the most about uncontrolled hypertension are those last two bullets. There is an inequitable prevalence of hypertension and uncontrolled hypertension by race and ethnicity. And there are also major geographic changes around the country. Those are just intolerable because of the last bullet, is that control is absolutely possible. The science is clear on this. The evidence-based practices that can help control hypertension are well known, but they're not available everywhere for everyone. It takes a balance of some public health actions, some healthcare actions, and some individual actions. I will hit the highlights of those. So why do we care about hypertension control? The answers are on this slide. What you see here over a 6 to 7 year period, 2010 to 2016 or 17, in the upper left corner, the red zones are counties where the death rate from heart disease is actually rising. And both of these depictions are in the population from age 35 to 64. We've seen a decrease in mortality in the 65 and older group for a number of good reasons. But in our workforce, in our parents, in our caregivers, we're actually seeing not just a rise in event rates, but a rise in death rates. Heart disease in the upper left corner and stroke rates in the lower right corner. Now, many of us who grew up or live in what's called the stroke belt are used to seeing red in our section of the country. But as you see here, these rising death rates from stroke and heart disease are from Maine to California and Washington to Florida. So we have really epidemic levels of rising event rates and mortality, death rates in this key section of our population. And hypertension is a major contributor to those rising death rates. I want to dive deeper into a subset of the population, comparing the outcomes for Blacks or African Americans and compared to largely to whites on this slide. I could create similar slides for American Indians, Native Alaska Natives, or for Hispanic Americans, or Asia Pacific Islander Americans. But here we'll look at the comparison of Black and African Americans. So you see the prevalence of disease is much higher in both men and women. The incidence of stroke is 2 to 3 times higher in Blacks and African Americans compared to whites, as is kidney failure. And basically all of these preventable diseases are much higher. The last bullet here on the slide is about the disparity in outcomes for African American or Black women in pregnancy compared to white women, 3 times the death rate. And a large contributor, again, is uncontrolled or undiagnosed hypertension. I'll just spend a moment or two on these pregnancy-related deaths, morbidities, and mortality. I've put in orange, the orange boxes, the cardiovascular contributors to maternal deaths. And the last category, of course, is preeclampsia and eclampsia. You are likely aware that these disorders are rising in incidence and frequency. And there is a huge disparity between Black and white, as shown in the lines that are purple for African American or Black, and red or orange for whites. Again, these conditions that cause maternal deaths will be reduced when we do better detection and better control of chronic conditions, including hypertension. I want to spend a moment more on these hypertensive disorders of pregnancy because it is of great interest now, I'm delighted to say, in this administration and many other partners, health departments, and clinical settings around the country, but we have some awareness raising to do. These categories, all of these bullet points, are encompassed by the diagnosis of hypertensive disorders of pregnancy. We know they're rising, as I mentioned before, and about 1 in 10 women will experience at least one hypertensive pregnancy. It's important to diagnose this, of course, and to treat it appropriately during that pregnancy, but it is also critical that women who experience hypertension during pregnancy have that identified in postpartum visits and for the remainder of their lives, because the occurrence of hypertensive disorder during pregnancy marks that woman for an increased risk of heart attack and stroke for the rest of her life. It's not only hypertensive disorders of pregnancy, but women who come into pregnancy hypertensive also are at increased risk. The maternal risks are over on the left side, and there are risks to the fetus and to the newborn. You can also measure the burden of hypertension in dollars. This is a map derived from a tool that Medicare has developed. These are fee-for-service. This is a comparison of the cost of care of Black or African American beneficiaries in Medicare compared to all races. The blue zones are where the discrepancy in cost is the greatest. So for example, in Greenville, South Carolina, I can't really highlight it here on the map, but the cost of Blacks or African Americans compared to all races is around $2,200 more annually, based just on the cost related to hypertension. We also know that Nashville here is in the blue zone. I encourage you to use that tool as you see fit. I put the link there on the bottom. So what are we going to do about this? In October of last year, 2020, the Surgeon General, Dr. Adams, released a call to action to improve control of hypertension. He did so even in the midst of the pandemic. As we know, people with COVID who had existing cardiac conditions were at increased risk for hospitalization, for ventilation, and for death. The large predominant of cardiovascular conditions would have been reduced had people had controlled hypertension. So the link between COVID and hypertension was pretty clear. And we also know, again, because of the crazy prevalence of hypertension as a condition and the fact that it's mostly uncontrolled in the country, is another reason, even in the midst of the pandemic, to draw attention to hypertension. I'm going to dwell in a moment on self-measured blood pressure monitoring, because although it's not the only thing we need to do to improve blood pressure control, it is a key thing and a very tactical and practical thing that will require many of us to act, and many of you in the audience hold one of those levers. So I encourage you to take a peek at this call to action. As a result of that call to action, a federal leadership council has formed. I'm very excited about this because there are key agencies that sit around this table now and are getting down into the weeds of the policies that they can create or modify to help accelerate improvement nationally in blood pressure control. The agencies listed here are current members of this council. It's an open table, so we're looking forward to having more agencies that have an oar in the water to help with blood pressure control. And let me say that once the Department of Health and Human Services sort of gets its act together for hypertension control, we very much hope to engage other agencies, other departments, USDA, HUD, transportation, many of the organizations or the departments that can help get upstream and really dig in at the social determinants of health that operate to fuel this epidemic of uncontrolled hypertension. This is the framework that the council is beginning its work with. I won't walk through these things, and these are not all the things that need to be done, but these are the actions that we feel federal agencies can weigh in on, how the federal government can make progress in control. I want to close my comments by just focusing for a moment on self-measured blood pressure monitoring. It is a key priority for the council, a good starting place for us, and we hope to make headway in short order in this regard. What is it? This is actually the new way, the best way to be identifying people with hypertension and helping those individuals control their blood pressure. If you stop for a moment and think, if someone is diagnosed with diabetes, what happens? They are educated about their diabetes. There are specific diabetes educators There are tools that a person is trained to use so they can self-monitor their blood sugar, and they're actually taught how to administer insulin or modify their activity based on the readings that they get at home. We don't require them to come into an office and be told or not told whether they have, what their blood sugar is typically. So why could we not transfer that same model to hypertension? Why would someone's blood pressure be a mystery to them? They should be in control of that. And this practice of self-measured blood pressure monitoring enables individuals to really become experts in their own patterns and to work collaboratively with their healthcare team to keep their blood pressure under safe control. I won't go through this, but I will try to convince you and can give you references if you'd like on the evidence base for this. There is no question that this is a more accurate way to measure blood pressure. It helps individuals avoid overtreatment or undertreatment. It's more convenient, and it really helps people, as I said, develop a sense of control around the factors that make their blood pressures go up or down. There are pockets of innovation and excellence all through the country, including in a number of federally qualified health centers. And this is the way of our future as soon as possible. I'm just going to quickly move to this chart. This will be in your slide deck if you choose to take a peek. I won't walk through these things, but a number of national leaders and people on the ground practicing SMBP have helped us identify what the obstacles are to making this practice accessible for all and to making it hum. There are challenges, as you see, with monitor availability, with cuff sizes and validity, and down at the bottom, an important one in terms of sustainability. There is now a code that clinicians can use to get reimbursed for this practice of SMBP with their patients and the exchange of data from the patient and advice back to that patient. So I want to share with you living proof that this can work. Let me just take a chance that we will be able to share this together. This video is a summary of a little project that Million Hearts did with a series of federally qualified health centers around the country. Just one story, but a powerful one.
One day, Deborah, she was my nurse. She wanted to check my blood pressure. I think my blood pressure was about 170 over 90, so it was pretty high for my age and everything. So she asked if I wanted to join the program with her to help see if I can find ways to lower my blood pressure.
We decided to let our nurses be the catalysts and the drivers of this program. In doing so, they were able to select patients that were not only appropriate for SMBP, but were engaged in the idea.
And the first step is figuring out what they do and do not know about blood pressure. Most of them do not know what the readings mean.
Also, we're going to be going over lifestyle changes. The amount of patients who are starting to realize that when they drink coffee and then they check their blood pressure an hour later and it's elevated, but the next day they don't drink coffee and their blood pressure is lower, they can make that connection that for them, coffee raises their blood pressure. So it helps them to be in charge of what habits they want to change based on how their body is affected by it.
Miss Deborah said that salt contains a lot of things that can make high blood pressure go up. When Mom found that out, she went on a salt rampage where she would take almost everything that included salt out. So it was pretty intense. There's a lot of change. I appreciate it, but I still like salt.
We're trying to give them the tools so they can succeed, so they can take what we're teaching them and use it to make them have more control over what their blood pressure readings are.
Having patient-generated data gives us that background. We always say when our patients leave the office, we kind of have that hole in the loop.
Nobody knows if you're actually taking your medication, whereas we send you home with a monitor. When you come back and see me, I'm going to be able to go to the doctor and show them this is how his blood pressure is.
That data helps fill that hole in the loop, and it gives us a better idea of whether we're on track with our blood pressures here in the office, or whether we need to maybe do some adjustments outside of the office. The real exciting part is seeing the collaboration with our nursing staff and the patient. Sometimes you'll hear them say, I stopped drinking soda, and they're really proud. That triggers an engagement with that patient that we may not have had in the past.
D'Angelo found that when he watches his blood pressure, it helps him to stay on track for doing other healthy lifestyle choices.
So that's what's really exciting, is we get to really take one facet of the patient's health and allow it to sort of infiltrate through their entire lives.
My blood pressure was lowered and everything. It's much better. Yesterday I checked it and it was around 108 over 60. So it's a lot better than it used to be.
And this is a free online set of modules that also include a module on SMBP, but many of the other evidence-based, tried and true practices that can help clinical settings control hypertension. And my last slide is, again, thank you so much. Look forward to questions and answers and participating on our panel. Thank you.
Thank you, Dr. Wright. Just a couple of questions for you. You mentioned the trend for hypertension control is dropping and the death rates are rising. I assume those numbers you showed were pre-COVID. What have you seen in the past year with COVID and folks deferring care?
Great question, Molly. And those were pre-COVID numbers. There is a lag time in our ability to get data nationally and reflect that data back. But what we do know from our partners and connections across the country is that during COVID, of course, the first thing was that people were not seeking care. They were not able to, and they did not feel safe going in for clinic visits. The measures that are used to track blood pressure control in the past have required an inpatient visit, either in a community health center or office or practice. And so the ability to measure, first of all, was compromised. And then for those who could get into an office, they may not have gotten in within the time frame that's usually used to calculate the measure. And then finally, for those practices and clinics that were quite nimble and could quickly adapt to a telehealth environment, their patients may not have had a monitor at home. So there was no way for the patient to know what his or her blood pressure was. So we are prepared for when we are able to measure that the pandemic has caused a reduction in control rates. And it's not only for those reasons, but also most of us have not had our normal patterns. We've been under incredible stress. So knowing that we were on a downward trend with the control rate, we expect that to drop even further. And so all the more reason for it to be elevated as a national priority.
Yes, thank you. I had another question, and you touched on this. Hypertension is costly. We know that. What is the community impact? I think about workplace productivity, that type of thing. What's the impact to the community, not just in cost to the healthcare system?
Yeah, I think one of the most traumatic impacts on the community is in individual families, lives lost. You know, as I said before, the thing that burns me about uncontrolled hypertension is that it is controllable, and it is the major cause of these sudden events that occur that take family members from us, or work companions from us, workmates. And so it just seems nonsensical to me that we wouldn't make an all-out effort to fix things that we can fix, and that is certainly hypertension control.
Thanks. We have time for one more question. It says, I noticed that you listed SMBP as not taking blood pressure by kiosk, mobile device, wearable sensor, et cetera. Can you explain why?
Yes, it's a strict definition, and it's based on the evidence, the studies that have been done to date. So those have all been done with monitors, ideally automated monitors, not the ones that depend on someone, listening to heart sounds, pulses. But So the evidence base that we have was generated based on those types of devices. We have not yet seen sufficient evidence base for monitors that are at the finger level or the more distal in the arm. And the kiosk data, I think, is accumulating. I'm very excited about that because I will speak, this is personal opinion, not a CDC opinion, that being able to have kiosks conveniently everywhere for those people who might prefer to take it at a pharmacy or a grocery store as opposed to having a device at home. What I want is every individual to be able to have the ability to track their blood pressure, whether it's at a kiosk, fire station, a community setting, the Y, rather than being necessarily dependent upon having a cuff at home. But the strict definition at this point is based on those prior studies. So looking forward to seeing the studies coming out of community settings and kiosk-based pressures.
Great. Thanks, Dr. Wright. It's now time to transition to our panel discussion. To guide our conversation today, we are pleased to have Ryan Petit-Frere. Ryan serves as the Senior Director of Marketing Communications for the Nashville Healthcare Council. In her role, she leads strategic communications initiatives, including the Council's COVID-19 readiness team and its diversity, equity, and inclusion efforts. In addition, she serves as the host of the Council's new healthcare history podcast, The Untold Stories of American Healthcare. Now, it is my pleasure to introduce Ryan.
Well, thank you, Molly. Nashville Health has brought together a really great set of speakers today as we march forward in addressing chronic conditions through COVID. We've got a wonderful panel. Joining us today are Dr. Parker Panovic, the Chief Medical Officer at Faith Family Medical Center, where he has been for more than 8 years. He's no stranger to the region. He came to Faith Family from Jackson, Tennessee, where he worked at the Jackson Clinic in outpatient medicine and wound care. Prior to this, he practiced and taught both inpatient and outpatient family medicine at the University of Tennessee Family Medicine Residency Program. And he's a graduate of University of Tennessee Center for Health Sciences, College of Medicine in Memphis. Dr. Panovic, welcome.
Thank you. Great to be here.
Great to have you. We are also joined by Dr. Amma Arthur Rowe, the Behavioral Health Medical Director at AmeriGroup. At AmeriGroup, Dr. Rowe develops and implements statewide behavioral health policies and procedures, and these help improve access to care and the quality of life of the plan's members. Before AmeriGroup, Dr. Rowe was an assistant professor of clinical psychiatry and behavioral sciences at Vanderbilt University Medical Center, and also an assistant professor of clinical sciences at the University of Kentucky College of Health Sciences. She's a triple board certified and a graduate of Meharry Medical College. Dr. Rowe, welcome. I think she said it's great to be here.
Yes, it's wonderful to be here. Thank you.
Fantastic. Lastly, a familiar name. We are joined on the panel by Dr. Janet Wright. We are more than familiar with her. She will be here chatting with us as well. Okay, well, let's get into it. Let's begin by getting the audience familiar with the work your organizations are doing and what work you do to reduce chronic care disease and improve chronic care disease care. At a high level, Dr. Panovic, what's your organization doing?
Yeah, so if you don't know, Faith Family was started 20 years ago. We started it in 2001. And the mission then was to really to provide good care for everybody that we could, especially those who were just kind of our hardworking neighbors in need is how they defined it. We partner locally with hospitals, specialists, imaging centers, and then nationally with a lot of the pharmaceutical companies in order to provide care to our patients, which is about $8 million a year on about a $2 million budget. So trying to really stretch those dollars if we can. And I like to say we take care of everyday people. And what I mean by that is we take care of the people that you see every day. They're the people who cook and serve your food in the restaurants. They're the people you see on the construction site. They're the people who are cleaning your office building or maybe your house. They're the people who are mowing the grass and dry cleaners. And it's, we take care of the people who make Nashville run. So it's just kind of the folks that are all around you every day.
Great, thank you for that. Dr. Rowe, tell us a little bit more about AmeriGroup and what you do to reduce chronic disease and improve care.
Yeah, so greetings to all. I'm very excited to be a part of the panel discussion today. So as the Behavioral Health Medical Director for AmeriGroup, that's where we sort of view the facilitation and the integration of physical and behavioral health services as just a vital part of overall healthcare. This enables us to successfully meet the needs of members with behavioral health and substance use disorders, as well as those with intellectual and developmental disabilities. Our mission is to address the physical and behavioral health care of members by offering a wide range of targeted interventions, education, enhanced access to care to ensure that these improved outcomes and the quality of life of our members are obtained. So this is especially true for those with chronic disease, as they are at an increased risk of poor health outcomes. We also collaborate with hospitals, group practices, independent behavioral health care providers, community organizations, government agencies, human service districts, and other resources.
Thank you. Dr. Wright, were there any other additional thoughts you wanted to provide about how CDC is improving chronic disease care?
Thanks so much, Ryan. I want to emphasize that the Division for Heart Disease and Stroke Prevention, whose mission is in its name, sits in the Center for Chronic Disease Prevention and Health Promotion. So my sister divisions focus on tobacco use, on cancer prevention, on diabetes control and prevention, and nutrition and physical activity and obesity. So, and there are other divisions, oral health, for example, and population health. So there is cross-divisional collaboration. And I will say, just from the agency overall, there is enormous action right now to extend and expand the traditional focus on reduction of health disparities into actual reduction in the impact of social determinants of health, and in being mindful and active in addressing the health inequities that underpin so many of the chronic diseases. It is really exciting to be at CDC at a time where this is clearly central to the mission in going forward.
Great, thank you. And we will certainly dive into health inequity further on in this conversation. But before we do, let's just dive a little bit deeper into our local organizations. Dr. Panovic, you mentioned you work with everyday people. Part of what Faith Family does is focuses on whole person care. What does that mean, and how does it impact chronic disease care?
Yeah, I mean, like I think a lot of primary care offices, what we see is hypertension, diabetes, hyperlipidemia, obesity. Over 60% of our patients have at least one of those, and many have all four of those. So obviously we're looking at chronic disease patterns for the vast majority of what we do. In the past, I feel like medicine traditionally tried to place each treatment or every part of it into its own little partition or silo, and didn't allow them to kind of interact with each other. And we've really been trying to break down those barriers so that we want to emphasize each part is as important as the other part, and we have to do all of them if we're going to get optimal care. We created, I guess it's about the time I came here, chronic disease days. So we started with diabetes. That was very successful. And then we added hypertension as our two kind of ones to start with. On Diabetes Day, we try to bring together everything that our patient would need. That's an annual event for them, but bring it to them all in one day. So our patients are working sometimes 2, 3 jobs, part-time jobs, inability to transportation or ability to get to us. And so we created this environment where if you come in a half a day, you're going to get your urine checked for microalbumin. You're going to get your foot checked, maybe sit down with a podiatrist and have a foot check done. You're going to sit down with a pharmacist and go over all your medication and do medication reconciliation. You're going to get blood work done. You're going to meet with your primary care provider. We have a dentist here who does an oral exam for you. We have an ophthalmologist here who does a retinal eye exam for you. And then you also get your dietary counseling, your exercise counseling. So just trying to bring all that together in one place instead of people trying to get off 8 days to go and make these happen. And actually our last one we added, we have a small group ministry that works upstairs. And so we said, hey, can we start to expand and create a group around people who have chronic disease and let them talk about how does diabetes impact me? How does it impact my family? How does it impact, how does high blood pressure impact my job? And I'm angry because I have to take this medicine every day. I don't want to take a medicine every day. So we added that piece in too. So it's an attempt to say that no matter whether you're on the nutrition side or the behavioral health side or in my office where I have my stethoscope, think of all of that as your care. All of that is important for this chronic disease process.
That's truly impressive. Chronic Disease Days, providing so many resources to people that you serve. Let's talk a little bit about AmeriGroup. There are more than 400,000 enrollees statewide, and you provide care to a large and diverse group of our fellow Tennesseans. How do you meet the needs of the diverse populations you serve? So many people, Dr. Rowe.
Yes. So we do serve a diverse group of Tennesseans, though there are common needs that we have found among our populations, whether they are in rural or urban areas. So you can take, for instance, food insecurity. This pandemic has highlighted the fragility of food access and how many people have just been affected by this. So AmeriGroup partnered with organizations hoping to address this need. And we noticed that organizations either had the food or the funds to purchase it, but not a way to store it. So this led us to the purchasing of new refrigerators and freezers for organizations, large or small, across the state to hold more fresh food, fruits, and produce for their clients, thereby encouraging a healthy lifestyle, especially when so many people noted that they were becoming more sedentary during the pandemic. So we also look to partner with organizations who can speak to the needs of a variety of populations. So including those who serve people with disabilities, pregnant women, different racial and ethnic minorities, and also using advocates from these specific groups to help us all come up with collaborative solutions to health problems. So, for example, working with the Hispanic Family Foundation to address specific health disparities. So co-hosting a community baby shower, given concerns for pre and postnatal care, and then continuing to be a part of the discussion regarding the rising rates of child and adolescent behavioral health concerns. And we could keep in mind that those rates were trending up and were noted even prior to the pandemic. Additionally, we've worked with groups, I'm hearing earlier about diabetes, such as JDRF and Fitbit, to help ensure that families as a whole have tools to stay healthy, because the link between physical and mental wellness just cannot be overstated.
Yeah, so many resources and so much work touching base with communities. Love what you said about the advocates and being in communities. Well, let's maybe take a moment and we'll pan out a little bit and talk about chronic conditions on a national level. Dr. Wright, this one is for you. It's about hypertension, your specialty. National health issue. Nearly half of the nation's adults have issues with hypertension and blood pressure. And only about one in 4 of those individuals has it under control. Locally in Nashville, 30% of Nashvillians are hypertensive. You mentioned education, self-measured blood pressure monitoring. Could you dig a little deeper into what other differences could be made and how we could get there?
I will, and thank you, Ryan. But I just want to say, Dr. Rowe and Dr. Panovic, I hear you both. What just so loud and clear to me is your ability to adapt to whatever someone needs. I hear you, Dr. Panovic, is you identified it's so valuable for people to come together and share their experience and learn from each other. Not always from a healthcare person, but from each other. And then Dr. Rowe, your ability to be flexible and say it's not the food access, it's keeping the food fresh and available on site. So I just want to applaud your efforts, and I hope we can do the same. We're not very flexible in government, but we'll try. But so back, Ryan, to the stat that you mentioned about Nashville, 30% of Nashvillians hypertensive. Let's be careful about that, because that's 30% who were diagnosed with hypertension. And that's part of the problem. If we don't get the diagnosis of hypertension out of the old model of walking in and sitting down in a clinic, or we don't expand our thinking about how to get it diagnosed, then we're missing people. We are clearly missing people. It's a phenomenon known as hiding in plain sight. And even for individuals who are seeing a regular clinician, they have a doctor or a nurse that they're seeing regularly, there are a number of people, it may be up to 12, 15, sometimes 20%, who are in care but have not been diagnosed with hypertension. So if you pour through the electronic health records using algorithms, you can actually find people with multiple elevated pressures, and yet they've not received a diagnosis. Now, not all those people will be hypertensive, but unless you pour through, gather those folks, and then have them monitor their blood pressures, you won't know. So that is one thing that can be done, improve detection by using the electronic health records, but that's only capturing people who are in care. Moving the measurement out to the community and trying to make it easy for people to record and track their pressures, making sure that then they can get a connection to care, will actually help us capture folks who have not yet been identified. I just want one other plug in, Ryan, and that is for using protocols in care settings. And Dr. Panovic or Dr. Rowe, I don't know if you all have experience with those, but my experience as a cardiologist is asking people, if you use a standardized protocol, if you go to a big place and you ask, are you using a protocol to treat hypertension? Oh, sure. Whose protocol are you using? Well, I'm using my protocol. Well, where's your protocol come from? Well, it's the way I did it, it's the way my colleague did it. And it turns out it's not a standardized approach, but it's absolutely clear that places that adopt a standardized treatment protocol, team delivered, so it's not only the physician, it's multiple team members who are executing that protocol. Disparities are decreased because you're treating hypertension, at least for the bulk of people, in a standardized way. That helps lift up those people who are not well controlled with the standard approach and they need a little extra attention. So I would encourage folks who are in clinical settings to develop a protocol that works for your team and your population and execute that.
A lot of what Dr. Wright is suggesting here has to do with protocol and approaches. Any additional thoughts on the particular topic around protocol or methods to identify and capture people with chronic conditions? Dr. Rowe, Dr. Panovic?
Yes, I do think that the ability to screen effectively for mental health conditions and concerns is even more important in this time. We've mentioned before the reluctance to seek treatment or seek care. So now you have people going back to their physicians and they're not exactly what may have happened in the past 6 months, past year. So really screening for depression, screening for substance use that may have happened in the primary care setting and not necessarily in the behavioral health setting. Also being aware, as Dr. Wright mentioned, that there are protocols that can help when you're addressing substance use disorder or starting an antidepressant or trying to find out how to manage pain in someone who maybe has a history of opioid use disorder. And so with the Merit Group, we are able to sort of provide that support and a bit of information if providers come to us or if we identify that this may be something helpful to a particular practice. And I do believe that it truly makes a difference.
Well, I love that we went towards mental health, behavioral health. This crisis has, among many things, highlighted the tremendous needs to access, to address and support mental health. We had a community forum about a year ago, and one of our panelists said, Right behind COVID-19 will come a demand for behavioral health services unlike anything we have ever seen in our history. When we look at what's going on locally, Nashvillians, this is in 2018 pre-pandemic, reported a full day more of poor mental health days per month than our peer cities such as Austin and Charlotte, and even more than the national average. So it's hugely important. We hear, Dr. Rowe, that diabetes, heart disease, those are discussed in the context of chronic conditions, but mental illness isn't often referred to as one. Is our experience in the pandemic changing this?
Yes, that's a great question. So mental health issues have increased during this pandemic time. And many of these concerns that we have noted in the past are now being forced out to the forefront. So it's definitely changed how many have viewed and conceptualized mental health concerns. And Dr. Wright mentioned hiding in plain sight, which I think is a great way to view what we're seeing now as it relates to mental and behavioral health. So when looking at the data shared by the Kaiser Family Foundation, on average, more than 1 in 3 adults in the US reported symptoms of anxiety or depression since May 2020. Compare that to the year before when that number was 1 in 10. And so speaking about those increased rates that we're seeing here in Nashville, keeping in mind that that also impacts the families and the communities, it truly is a rippling effect. And then looking at Tennessee, in January of 2021, over 4 out of 10 reported symptoms of anxiety or depression. And so when we're thinking about whether or not you can place mental health concerns as a chronic condition, I think that you think of it as a continuum. So it can be acute to chronic. It's possible, for instance, to have a single episode of depression that is time limited and never reoccurs. But for many, the diagnosis of depression, other mood disorders, anxiety, psychosis can be viewed as prolonged conditions that wax and wane, increase and decrease with their symptoms that are presented, but they are also treatable and must be included as an integral part of that person's overall health story. So if you don't think of the chronic nature of these diagnoses, then you're really missing the impact that it can have in that individual's health. We can also think again of how health models have changed over the years as it relates to substance use disorder and addiction. So that's moved from being viewed as a moral failure and is better understood as a chronic condition that includes relapse and recovery.
Great, thank you, Dr. Panovich. Thoughts on this, and could you give us a sense of how impactful this past year COVID has been for the people that you serve, especially the vulnerable and isolated people out there?
Yeah, like you said, it's been incredible. People who've never, disclosed any kind of behavioral health problems are being much more open, which is really good. And hopefully partially it's because we've been more sensitive to that and asking those questions. We've seen it on both sides. I mean, it's even now, I think, as we're seeing, mask mandates going away, we've had people who were afraid because of getting the disease and what would happen to them or what would happen to their family. But we've also seen people who've just been terrified of the social isolation, that removing them from their, ability to meet with family, to meet with friends, to meet with church. And we saw a lot of just isolation that was also a big part of that. We worked really hard here, like I think every clinic did, to let our patients know that we were screening. We asked you, I think 4 times before you ever made it to the back, all those COVID questions. And I know it was just overkill, but you could also get a sense of peace that we were asking those questions. We created an outside COVID clinic so that people could, they'd show up, pull into a designated area, call and let us know they were there. We would go outside to them to see them so that they knew, I'm sick, I want to be seen by my provider, but I can do that for you. But we also let people who are coming into the building know, hey, we're keeping people out of the building who are saying, I am sick and I have these things. So we really tried to create separation and to reassure them we wanted to help them, but to say we're going to create this barrier that's going to be there. So we try to do a lot of things to reassure people during those times. But it was certainly is and was a challenge.
Absolutely. Well, there's certainly some learnings that come out of this, some new practices, some new attempts. I think we've all tried to be very agile, pull extra strength from some reserves in other places. So let's talk about that. Let's talk about what everyone has learned during this time. What did you try, and what are you going to keep in practice as we move through COVID?
Well, I'll jump back in since I guess I was there. It's interesting. We called it the COVID clinic, so it was outside, and at first it was just all COVID, and so we were doing tons of that. But it was interesting that all of a sudden we realized that we had these people were using it for like work-in spots as well. My nurses are sneaky; they know how to get more people in, which is good. The funniest one, and what was actually, there was a gentleman who wanted to get his prostate checked in the COVID drive-up clinic, and I thought, now that is going to be a trick. And we decided not to do that one. We moved that one indoors. Yeah, I couldn't figure that one out. But we are going to keep a clinic. We're certainly keeping it for now for COVID. But we've thought about other things too. During flu seasons and different things like that, we're going to have some clinics to try and reassure people that we're going to keep you as safe as we can, and not just from COVID. We also, of course, like everyone, I think, put in place telehealth. And so we will definitely keep telehealth. I'm a huge proponent of telehealth, I think, for behavioral and for wellness. People are saying, hey, I can talk to the dietitian for 10 minutes on a telehealth visit and not have to try and get 30 minutes there and 30 minutes back home. So we view this as a tremendous opportunity to keep people engaged in their chronic disease processes for their high blood pressure and diabetes. We did virtual cooking classes. We did virtual exercise classes. So we did some things that I think are really going to carry over, and we're going to really try and keep that piece in, because we have been able to overcome at least a transportation barrier with that, as well as a time commitment barrier. We're still working on, the access barrier too. So, but those are definitely lessons we learned, and we're going to keep those.
Fantastic. Same question, Dr. Wright, Dr. Rowe?
Well, yes. I'll touch on 2 points that Dr. Panovich made that are, I think, are right on target for what we're seeing as well. So before the pandemic, loneliness was already being viewed as a public health concern, given it's associated with reduced lifespan and a greater risk of both mental and physical illness. And so before the pandemic, we also had young adults, women, racial ethnic minorities, who were noted to be a part of these vulnerable communities and at risk for poor mental health outcomes, substance use disorder, and those barriers to accessing care. And then we noted that, okay, a lot of the people that we are seeing are also dealing with significant losses. And so loss of family, loss of job, loss of support system, loss of being on campus for education, housing, which just sort of snowballed into the anxiety that was mentioned, that fear, that social isolation. So when you put all of that together, it was definitely this boom that we noted. And so AmeriGroup, we sort of started off just by doing check-ins with the members to make sure that they were able to shelter in place safely. And we found that many of them were able to do so, didn't have any acute needs, but really enjoyed having someone to talk to and to care for them. They felt in that a very vulnerable time. Also, talking about telehealth, it became a way initially to just have a safety net when traditional visits were not an option. Well, this also worked for many people who had the inconsistent transportation, childcare, work schedule that was there. But as we sort of transition to telehealth, we saw it worked really well for a certain population. We were able to have our behavioral health care coordinators work with our BH case managers to complete over 500 virtual face-to-face Zoom visits for members. It started with youth, they went to adults because of its success. But it also brought up another concern about digital equity within these communities. And so Amerigroup recently purchased telehealth kiosks for a rural housing authority to provide access to those who may be more at risk for leaving their home. We did realize that not all areas have broadband, but it's not just our issue alone. We did see that, okay, a large part of Tennessee is connected to the internet, and our governor was focused on ensuring that internet was brought to all communities across the state, but that digital divide was still there. It affected many members in different parts of our community and sort of kept them from being that active part that they would have liked to have been because of that. And we found out that cost was prohibitive. So you may have had access to internet in theory, but if you can't afford the fee or if you don't have a reliable device, you're not able to stay connected. So Amerigroup really took charge on that, supplied $350,000 in funding to update internet connectivity, purchase laptops, and provide technology to those without. Really understanding that we need to close the gap on that isolation. We need to have people in contact with their providers, have our children and youth have that virtual learning and that quality that they could have in a very stressful time, and allow them to connect with their loved ones during the difficult times of the pandemic.
Thank you. Thanks for that. I do want to move on, but I'm going to pose a hybrid question then to Dr. Wright. So same question about what's going forward in your organization. What are you going to continue from your learnings of the pandemic? And additionally, let's talk a little bit about partnership and collaboration too. There was a lot of effort to utilize resources and staff and communities coming together, industries coming together. What, from your perspective, Dr. Wright, also is going forward in terms of collaboration?
Yeah, so thank you. And I was so deep in absorbing what Dr. Rowe and Dr. Banovic said, I sort of forgot I was a panel member there. But on the telehealth, I also was a fan in my practice. And if the pandemic did one good thing for us, it was to allow us to do what we all knew would be a better way to manage some situations, or to really be patient-centric authentically. So what is convenient for that individual? So I'm very hopeful that the regulations around telehealth stay in place or even expanded as we move into a post-pandemic or the after times as opposed to the before times. I will say from a hypertension standpoint, every year Million Hearts recognizes high performers in hypertension around the country. And because of the blow that all those practices and clinics have suffered as a result, and patients have suffered as a result of the pandemic, this year, Million Hearts is going to recognize exemplars. And by that, we mean places around the country that recognized early on that hypertension control was going to suffer, and they made adaptations. We've learned already from a number of places how they had, took meds to doorsteps in order, because people weren't able to get their medications in the early days. A number of innovations. And we're not even asking people what happened to their control rates. We just want to gather how they adapted and maintained a focus on hypertension in the midst of this chaos. So we hope to be releasing those exemplars over the next year. In terms of partnership and collaboration, I will tell you that our little division, much less the agency, cannot do its work without strong partnerships. Predominantly, our partnerships traditionally have been community-based, so state and local and municipal health departments. They receive funding from CDC, but they also, in spirit, are strong partners. And then there are a number of other organizations, clinical, professional, whose missions are aligned with ours and who we could not move forward without. I certainly would consider Nashville Health and now the Nashville Healthcare Council part of those partnerships. over. You can tell I've been doing COVID response, over.
Great, thank you. Yeah, there's a great point here too. You're mentioning these exemplars and gathering information about what people have done. There's some growing sentiment that as vaccine accessibility reaches new heights and restrictions around COVID are loosened, there's some growing sentiment that this is nearing over, but there are still some very, very important steps ahead of us, which namely recapping and memorializing our learning simply as a means of just improving the future. So thank you for that note about looking back and taking note. Okay, great. Let's move on a little bit around investment. So collaboration, talked a little bit about that. Chronic disease and behavioral health issues impact not only the individual, but families, the entire community. How can we foster greater support and investment to improve care and communities? It's a free-for-all.
Okay. One of the things that we have done, and this is not something new for us, is that we have engaged families in our wellness programs, in all of our wellness programs. It seemed like a really easy way to sort of include family members. And so whether it is dietary counseling, we always encourage whoever is the primary people who either buy and or prepare the food, come with the patient if they're not the patient. But we also encourage them to bring their kids. And so I've been in on dietary counseling where I've got a mom and a dad and a couple of kids, and everybody is getting to see that. Prior to COVID, when there were 5Ks, you remember those things people would go out and like do 5Ks? Yeah. We would try and do 2 or 3 a year as a clinic. And so the providers, patients, all of us would all get together, and families were invited, and we would all go out and participate in walking 5Ks together. We have a garden that's a demonstration garden here at our building. And again, we encourage the families to come and to learn about planting and tending and gathering, and then we bring them inside and we cook them. So cooking demonstrations. So we really are looking for that multi-generational impact. It's great if my patient gets that one-on-one care they need, but so much better if we can get into their whole household and impact the partner and the children and everyone else who's in there. I think our success rate, I'm selfish, I want my patient to be successful, so I think my patient success rate goes way up with that. But I'm also love getting that multi-generational effect to impact the environment that's there.
And Dr. Panovic, a follow-up question for you, especially around investment. How important is investment in Faith Family Medical Center to your operations?
Define investment, because we love donations, if that's what you're asking.
I'm talking about donations.
That's right. Yeah, I mean, patient revenue probably generates about 15% of our budget, and so fortunately, I have some very talented people who work and get the message out. But absolutely, we could not do what we do without the people who financially invest in us. We have individuals as our biggest source, but then we get lots of other investments. And I tell people, like I told you guys earlier, at a bare minimum, we're promising you're going to get a 4-to-1 return on your investment. We're going to get $4 of care out of every dollar you give us. I really could, make that a lot bigger. I mean, we did a study looking at impact on our 3 local emergency rooms, and we keep almost $8 million a year out of the emergency room. That's not even counted in our budget. So I would love to go to all their CEOs and tell them they should just totally fund us, because look at what we're doing. But so far, I've maybe not been that bold, but I'm getting there.
You're certainly doing great work. Dr. Rowe, same question. How can we foster broader support and investment to improve the care that we're providing in our community?
So we must take into consideration the social factors that goes into a person's health. So we know that 40 to 60% of an individual's health is driven by external factors, such as access to care, access to food, shelter, and safety. So AmeriGroup is working with providers to identify the social determinants of health and provide patients with solutions by referring them to community-based organizations. And really going to the point that Dr. Panovic was making, by identifying these issues in the individual, it is then our goal that the local organizations will be able to provide the support, not only to the person, but then to the families who support that individual. So often it is the entire household who receives services when it started with just one identified patient in need. I think also understanding how stigma impacts the individual and the community when those who are in need are reluctant to seek beneficial and at times life-saving care. So discussing mental health openly and freely, educating yourself and others about mental health as a part of this total wellness picture on par with maintaining your overall physical health. We know with stigma comes shame, which can then further exacerbate mental health conditions and increase poor mental and physical health outcomes. And so just, for depression alone, over $200 billion per year has been estimated as the cost. You're looking at alcohol use and drug use, which accounts for over a trillion in societal and economic loss. And so really providing that space for those in need to be able to feel supported in getting that care just makes a huge difference. And also just sort of thinking about the community as a whole, it's important to closely follow those key issues that impact our state and our local areas. So for instance, the Tennessee Department of Health Vital Signs dashboard allows us to sort of keep pace with our progress on various health concerns. And so that includes issues such as frequent mental distress and drug overdoses. And that helps us make sure that we're all working together with our partners and our members, our providers on health concerns that matter most to our state.
That's fantastic. Thank you for this. We are nearing the end of our panel and then we'll go into questions. So if you do have questions, please add them to the chat feature in Zoom, and we'll be doing that in just a moment. We have started to talk about resources. Thank you, Dr. Rowe, for mentioning Tennessee Department of Health. The Nashville Community Health and Wellness Survey was conducted by Nashville Health and MPHD in 2018. It's a really useful resource out there to get a sense of what's going on locally pre-pandemic. Panelists, what other resources are out there that are valuable for our audience members to look at to improve the health of their patients, their employees, their friends, their families?
I'll just maybe jump in and say cdc.gov, one set of resources, millionhearts.hhs.gov also has some for both public health and clinical folks. But I just will use my chance at the microphone here to riff off of what Dr. Rowe said, tying together the stigma issue, which is so incredibly powerful. And I do see some of the stigma around behavioral health and substance use in particular dropping a little bit because we're able to talk about it now. But one curious thing, I've spent my life in cardiology and cardiovascular disease prevention, and there's a funny little twist. It's somehow people who have heart attacks or strokes are sometimes, their own perception is they come in two flavors. One is that if I were more diligent about my practices, if I ate better, if I exercised more, they sort of self-blame for it, or there's a perception of blame that it's their fault that they got this problem. And then another sort of twist is that it is inevitable. Because heart disease is so common, it's in some families, it's just you're waiting for the cleaver to fall. I just had this conversation with my son-in-law last night, whose best friend from high school died suddenly at age 43. My own brother died suddenly at age 40. And if you have this in your family, there is a sort of the threat that hangs over you that can result in your just abandoning any sort of positive health practice because you think this is your destiny. And so it's a funny thing I'd like all of us to push back against, that heart disease in particular is largely preventable. And it doesn't take dramatic, it's not the marathon that you have to run, it's a small step or a few small steps, just persisting over time. So I hope to, if you're not already, all of you already preaching that or aware of that, please join me in doing so, because I think we can make huge headway with small steps. Over.
Yeah, just specifically for resources, for people who do not have insurance, there is the TCCN, which is the Tennessee Charitable Clinics. There's the, I just looked at it this morning because I have a patient who's moving to Texas and I'm trying to help them relocate. They were like, well, where can I find a clinic like yours? So there's the National Association for Free and Charitable Clinics. So nafcclinic.org. Sometimes people just don't know. I mean, I have people who are moving and they're just afraid to leave. And so having some of those resources can be helpful too.
And yes, I think what has been discussed is right on target for us as well. We have resources available with the Merit Group on our site. We have community partners that we work through based upon what the need is for that individual and that population. And then sort of touching on what Dr. Wright was saying, as far as sometimes it's almost a learned helplessness as it relates to some chronic conditions, that this is my lot in life, this is my fate in life. And providing that education, which is part of what we can do if they're experiencing anxiety or depression associated with it. So there truly is this bi-directional relationship between chronic mental health and chronic physical health concerns. So really getting to a place to where the left hand knows what the right hand is doing, and realizing they're both attached to the same body and the whole person can really make that difference. And it seems as if what is also happening with Dr. Panovic now is really addressing that. So there's this holistic view that then allows there to be some trust between the patient and the provider, and then they're more open to the suggestions and resources that are provided.
Great, thank you. Thank you for that. So we are going to move on to questions for a moment here. And to be honest, as I look at them, my measly degree in biology has not equipped me to understand them. So it's a wonderful thing that we have such an esteemed panel here today. I'll just go ahead and read this question from Genesis. It says, surprised to see many of the most convenient, prevalent, and easy to use SMBP options were not considered viable. Why? And what are those?
Yes, I think that was a flashback to the notice that kiosks were not included in SMBP. So I might have answered that related to where we have evidence. Lack of evidence doesn't mean a lack of benefit, but we just don't have the studies yet documenting that those more community-based technologies are as effective as a home monitor. Hopefully we'll have that evidence soon. I will just say on one of those slides I showed, there is something called a VDL. And one of the most frequently asked questions we get is, what kind of monitor should I buy? The AMA did an enormously solid for all of us by developing with manufacturers a validated device list. It's VDL.org. And there are listed devices that have been through testing and have shown to be user-friendly and validated for the reading. So I would encourage anyone who's shopping for a monitor to shop there.
And any advice on where to shop for a blood pressure monitor? I was taken with the video.
Yeah, aren't you? Me too. I love that video. Yeah, drugstores, Amazon, lots of places. Yeah, okay. And cuff size is really important. So make sure that you're getting one appropriate for your, I see Dr. Panovic nodding, for your arm size.
Thank you. Okay, another question here. Oh, go ahead.
The only thing I was going to say about blood pressure cuffs is, and I think probably a lot of us do this, is I encourage my patients, bring it with you. Let me check your blood pressure here in the office with your cuff compared to with the one we have in the office, because I do want to see the cuff size, and I want to, to know. I tell them it's more important to me to know that it's a reproducible number than maybe exactly how accurate we are. But yeah, I really want to do that with my patients.
Nods all around on this one. I see Dr. Rowe nodding as well. Okay, next question. I work with a senior living population with an average age of more than 80 years, pertaining to management of chronic health conditions, hypertension, DM, heart disease, etc. What do you think the senior living industry could do to better partner more effectively with health systems?
Well, so I have a very narrow focus on our call today, but having a place where individuals who live in that facility can check their blood pressures and have a conversation with someone there who understands when to pull the trigger and make sure a clinician is aware of those range pressures be very helpful. So developing, strong connections with healthcare professionals who serve patients or individuals living in that facility, to me, would be the no-brainer. Making cups available would be helpful.
And I will also add, that's a great population to screen for depressive symptoms. And so we know that pseudo dementia or reversible cognitive impairment actually is depression in this population, but it's actually missed and is assigned as something else. So screening, geriatric depression scale, just sort of keeping that in the realm of possibility and discussion, knowing that it runs hand in hand with chronic health conditions, could also be very helpful as well.
Great, thank you. Well, we have talked about so much important information here today. And for the group of people that we have in this call that are focused on public health, I'm going to start with Dr. Rowe. If you could just leave us with, one major piece to take away, one set of words of encouragement that you would leave this group with as we look towards addressing chronic conditions, what would it be? We'll go Dr. Rowe, and we'll go Dr. Panovic, and then we'll go Dr. Wright.
I am going to sort of double down on reducing stigma, because that is something that people may not realize that they're doing in their conversations with others. Language matters. So really creating that space so that those who are in need can get that care, and having education so that you can sort of understand what some of those signs or symptoms may be when someone you love may be experiencing a crisis. And so we really want to get to a point where these symptoms and signs are not minimized, but there is space created for them to be addressed with a number of behavioral health providers throughout the state. I do believe that things will continue to improve. We're learning more and more about how the post-COVID presentation increases psychiatric symptoms, but we also have very good treatment options available for those psychiatric symptoms as well. So there is hope on the horizon. Please seek help and seek care, and we are wanting the best for you in total wellness.
Yeah, when I was a resident, my residency director, if we ever ran up on a patient that was very difficult and we couldn't figure out what was going on, his piece of advice was always never go down alone, which meant you just ask for more help and ask for more help and ask for more help. And I think, if I could get my patients to have that mindset of never go down alone, and involving, like you said, you're involving your partner, involving your kids, involving your parents. And we're trying to involve the next generation of healthcare professionals. So we're working with students and residents and to make sure they understand in this kind of a setting, no matter where they end up practicing, how do you take care of people who have that need? I've twice in the past 2 days, I've had new patients come to me because they said they went to their doctor and they said, I can't take care of you because you don't have insurance. And I said, well, did you ask him, what if I have a big bag of money? Does that help? And one of them said, yeah, I actually did. And they were like, no, we can't take your money. So just man, don't allow a no to stay a no. Don't just stop at asking for help one time. Just please let us help you. There's those of us out here who love to do this and who want to be in your corner. So yeah, don't go down alone. Keep asking for help. We're here to help you.
As sage advice from both of my fellow panelists. I guess I will add or try to add that we've all been rocked by the pandemic. It's changed our lives. It's changed lives all over the world, and claimed lives. The fact is, cardiovascular disease still claims more lives in this country. It's still the #1 killer. It's the #1 killer of women and men. There are profound disparities, health inequities related to cardiovascular disease. It is largely preventable, and we know what to do. So, knowing that I've been focusing with you today on hypertension control, I'm going to ask each of you to get a cuff, to measure your own pressure, to develop a relationship with a clinical person with whom you can exchange your readings and get advice if you need it. Share that cuff with your neighbors, with your family members, and let's get this thing under control. Over.
Absolutely. Well, that is all the time we have today. Speakers, we owe you a great deal for not only joining us, but for your commitment to the service of others. Dr. Parker Panovic with Faith Family Medical Center, Dr. Amma Arthur Rowe. I'm gonna try that again. Dr. Amma Arthur Rowe of Amerigroup and Dr. Janet Wright of the Centers of Disease Control and Prevention. Thank you. Now I'm turning it over to Haley Hovius.
Thank you all our panelists. Y'all were phenomenal. Ryan Petit-Frere, our Nashville Healthcare Council's own. Thank you for moderating that discussion. I want to thank our sponsor for today, Bristol Myers Squibb. And then the wonderful thing about Nashville is that we have amazing partnerships here in this community. So I cannot wait to thank Molly and the team at Nashville Health for letting us partner with them on that. And to all of you who joined us today, have a wonderful day and thank you for being here.